Hello.
Good afternoon and welcome to NITRD CTD NTF Difficult to Treat TB Clinic. Today, as you all know, is Guru Purnima. We start the session by paying our deepest regard, respect and gratitude to all the teachers and seniors who have joined us. We welcome DDG TB, Dr. Joshi and his team from CTD, Director and faculty from NTI Bangalore, NIRT Chennai, district TB officers, directors of STDCs, faculty from medical colleges, medical officers, a very warm welcome to all. I am Dr. Neeta Singla. On my right is Dr. Rupak Singla, who is head of the department TB and chest at NITRD, and on my left is Dr. Amitesh. He is a pulmonologist at NITRD, and we are supported by technical team from ECHO India, Mr. Ankur and Mr. Manjeet. A warm welcome to all of you. And now I request our director, sir, Dr. Divan, to give his introductory remarks. Sir, you need to unmute yourself.
Good afternoon, everybody. Thank you, Dr. Neeta. Welcome. And I, on behalf of the National Institute of TB and Respiratory Diseases, I welcome all the delegates who have taken time out to join our difficult to treat TB clinic. As I am looking, 110 participants have already joined, and our usual attendance is 700 to 800. And by the time we come into flow, more and more people will be joining. As already communicated, senior chest physician, Bhisham Pitama of TB medicine in India, Dr. Rajendra Prasad is expert today, and my senior colleague, Dr. Rupak Singla, will also be giving his comments with the case. And we have seen that the cases which are discussed in difficult to treat TB clinics are so instructive and so variable every time. They keep on learning more and more by the discussions which are generated, and discussions are always high class. The DDG, I welcome and thanks, express my gratitude that he keeps on joining this meeting at every occasion and inspires us. Thank you so much, all the senior faculty and people who have joined. Welcome you to the NITRD TB, difficult to treat TB. Thank you, Dr. Neeta. Go ahead.
Thank you, Dr. Divan, sir. As you all know, we are doing these sessions in rotation where each state is given an opportunity to present the difficult case from their state. And in today's clinic, we have state of Rajasthan, and we thank STO sir, Dr. Vinod Kumar Garg and his team for supporting today's activity. Rajasthan is doing their own state level difficult to treat TB clinic for almost a year now. And today's case is being presented by Dr. Ankur Gupta. He is a Senior Medical Officer, DRTB Center at Ajmer in JLN Medical College. And expert from the state is SMO in Department of Pulmonary Medicine, Dr. Hemant Borana from SN Medical College, Jodhpur. The national expert for the day will be Dr. Rajendra Prasad, sir. Sir needs no introduction. He is currently Director Medical Education, Professor and Head of the Department at ERA's Lucknow Medical College. A very warm welcome, sir. And over to Dr. Ankur for the case presentation. I think we are facing some technical issue. Dr. Ankur will join us shortly. Is Dr. Borana there?
Yes, ma'am, I've joined.
Yeah, Dr. Borana, since Dr. Ankur is not able to present, will you be able to present the case, or do we present it from our side?
Yes, ma'am.
Dr. Ankur is not able to join for some technical glitch.
Okay, ma'am.
So do you want us to present the case or will you be presenting the case?
As you advise, ma'am.
We couldn't get you, sir. Can you?
Am I audible, ma'am?
Yeah, you are audible now.
I have to present, ma'am.
Yeah, can you present or you'll have some problem in presenting? Dr. Burana, can you hear us?
I can hear you, ma'am.
Yeah, so Dr. Burana, I'm asking that since Dr. Ankur is not able to join, Dr. Ankur, is he here? Yeah, Dr. Ankur has joined, so that's good. Dr. Ankur, you're there? Unmute yourself, please.
Yes, ma'am, I'm present.
Yeah, great. Welcome, Dr. Ankur. We know you couldn't join for some technical issue.
Yes, ma'am.
Yeah, so over to you for your presentation.
Ma'am, is my screen visible?
Yes, it is visible.
Good afternoon, respected teachers, and warm regards for Guru Purnima to all the respected teachers. I'm presenting a case of difficult to treat clinic. This case is of a 27-year-old male presented.
Dr. Ankur, थोड़ा slideshow mode में ले लेंगे presentation में.
Ma'am, it's in the slides mode.
चलो. हाँ, एक बार screen बंद करके दोबारा कर लीजिए. Reshare the screen.
Start video, ma'am.
Is it visible now?
Yeah, perfect, perfect now.
Thank you. 27-year-old male patient presented on 8th of January with complaints of cough with mucopurulent expectorations, dyspnea, fever, chest pain, with no complaint of anorexia. There is no family history of tuberculosis, no addiction or substance abuse, no history of chronic illness like hypertension, diabetes, and thyroid, and patient was manual laborer by occupation. Yeah, on ATT history, the patient has history of previous antitubercular treatment in 2021. Patient was started on DOTS, but within a few days, patient developed adverse drug reactions in the form of nausea and vomiting. The treating physicians there stopped the ATT and they started streptomycin, ethambutol, and levofloxacin. Patient was again restarted on HRZA after 1 month. Again, nausea and vomiting was restarted. Then patient went to a private practitioner and there the regime was modified and isoniazid, pyrazinamide, ethambutol, and levofloxacin were started. Pre-treatment evaluation in nodal DRTB center was done. All the basic labs were within normal limit. ECG was, heart rate was, UTC was 423 millisecond. Various evaluation in the form of ENT, CTVS, ophthalmo were within normal limit. Psychiatric evaluation suspected presence of depression and adjustment disorder, and they prescribed the sertraline and quetiapine to the patient. We first, in the meantime, the first line and second line reports were available, and according to these reports, patient was labeled as pre-XDR at that time. And the sputum, the latest sputum before the start of treatment was positive also. This was the X-ray of the patient. We can see that there are bilateral fibrocavitary disease more towards the right side. This is the mutation analysis and clinical interpretation of that mutation analysis, following which we decided to make a regime comprising of bedaquiline, delaminate, linezolid, clofazimine, and cyclosamine. ATT was started on 8 Jan 2022. Patient again admitted on 16th Jan, that is after 8 days, due to complaint of incoherent speech, low mood, irritability, and poor sleep. The psychiatric opinion was taken, and they advised to stop cyclosporine. Patient responded to intervention, and the current regime was modified according to that. We had dropped cyclosporine from the regime, and bedaquiline, delaminate, clofazimine, and linezolid were continued. In the meantime, patient went to Jaipur, and then he took a consult from a psychiatrist from there, and they started some medicines as they were the same as before. Those were prescribed here only, and patient is already taken those medicines also. Now the questions regarding this case, we have 3 questions. Number 1 is, what will be the drugs to be used when bedaquiline and delaminate are stopped at 6 months? Now 6 months have completed, so this is the time that we have to take the call. Then also, what regime we shall use if linezolid also needs to be stopped due to ADR? And third is, can cyclosporine be restarted when patient is stable with medicines?
Thank you, Dr. Ankur. Thank you for presenting the case. If there are any questions to Dr. Ankur regarding the case, we can take them now on the history of this case. Any questions? Are there any questions on the chat?
May I come in?
Sure, sir.
When patient presented first time, I believe from the history to the government sector, where DARTS was started, the DARTS category 1. Is it
Dr.
right?
Ankur, you've got the
Ankur?
question.
Yes, sir. Yes, sir. Patient was started.
Okay. But that time in the history, just I wanted to know whether he has a previous history of psychiatric illness or not. Or it has, because when he came to the government, when pre-treatment evaluation, you have written that there was some psychiatric illness.
Yes,
So
sir.
before the first treatment, has there any previous history of psychiatric illness to the patient?
So there was no history of any psychiatric illness. There was no history of any prior medical.
No, it was written there. I have read that. So is that correct? Because when he was evaluated, when he came to the program, you found that there is some problem of psychiatric issues in the patient.
Sir, yes, sir. Sir, it was the.
Probably the history for the first time may not have been taken properly. That was my message.
Sir, sir, we have taken, after the psychiatric consult was done as a pre-treatment evaluation. After looking at the opinion of psychiatrist, we cross-checked and we asked the patient again whether are you taking any psychiatric medications before also. So patient categorically denied any intake of psychiatric medications. So that's why the psychiatrist which have put down the notes, they have written it as a query. Whether this is, they are also not sure. They had because the patient has sometimes irritable mood, sometimes, but most of the patients in MDR TB we have these complaints are not very uncommon. So we didn't thought at that time whether this is, we continued with the psychiatric medications as it was prescribed, and we thought that patient will be tolerating these medications.
Okay.
Thank you, Dr. Ankur. When we started the case history, there were about 80 spokes, and now we have about 230 spokes. So I will just give the history in short so that everybody knows the case. This is a case from Rajasthan and it's being presented by Dr. Ankur, who's attending to this case. He's a 27-year male, started on FDC, EHRZ, but within few days, patient had to stop rifampicin because he could not tolerate it due to repeated vomitings. They made all attempts to restart rifampicin, but they could not. So they replaced rifampicin with levoflox due to this ADR. And after 7 months of treatment, patient failed. And the last culture that was done that showed INH resistance as well as high level MOXIE resistance. So patient was started on all oral longer regimen where MOXIE was replaced with Delamanid. Now patient is not able to tolerate cycloserine. He has developed psychiatric issues. So Dr. Ankur has 3 questions. Number 1, what replacement drug to be given in place of cycloserine? Number 2, what should we do in continuation phase when we have to stop bedaquiline also? And number 3, for any reason, if the linezolid needs to be stopped, what should it be replaced with? So with these 3 questions, we go to Dr. Hemant Burana, who's the expert for this case. And he's from Rajasthan also. So Dr. Burana, over to you for your comments.
So first question is, am I audible, ma'am?
Yes, you're very clear. Dr. Hemant, please.
So first question was that, first of all, good afternoon to all of you. Sadar Naman and Charan Spars. So सभी गुरुजनों को मेरा ये सौभाग्य है कि मैं यहाँ पे डिफिकल्ट टू ट्रीट क्लिनिक में एज एक्सपर्ट बात कर रहा हूँ. बहुत बहुत धन्यवाद नाइट्रो इको को. So first question was, what will be the drugs to be used when bedaquiline and delamanid are to be stopped at 6 months? So according to the PMDT guideline, since the 4 drugs which we have used are bactericidal and sterilizing agent, so and the effect of bedaquiline still remains in the blood after stopping for around 5.5 months. So 3 drugs will be effective even after stopping drugs, means linezolid, clofazimine and bedaquiline. And the second is, according to the PMDT guideline, we can start cycloserine since the drug is very important and it has we have to judge risk benefit ratio under the consultation of psychiatrist to start cycloserine again with the medical consultation and with the drugs, antipsychotic or antidepressant drugs as prescribed by psychiatrist. So then the regimen will be like if the patient doesn't have some psychiatric ailments or can tolerate drug like cycloserine, then we will continue the cycloserine for further period of 12 months. And the second question was, what regimen we shall use if linezolid also needs to be stopped due to ADR? As we all know that after 6 months, the linezolid dose will be halved to 300 milligram. And if in case of linezolid causes myelosuppression, anemia, bone marrow suppression, peripheral neuritis, then we have to consult to the neurologist. And if the neurologist advise that we have to stop linezolid, since the linezolid is a very important component of the regimen, so we shall continue the drugs. And if the drugs to be stopped and even the cycloserine has to be stopped, then according to the guideline 2019, if 2 drugs are stopped in CP, then we have to replace the drugs according to the replacement sequence and according to the culture sensitivity, even DST available to us, like pyrazinamide, ethambutol. And since the first line LPS shows that ethambutol cannot be used, so my choice will be according to the replacement sequence: pyrazinamide, ethambutol, and in past will be the third choice. And even if imipenem if used to be. And the third question was, can cycloserine to be started when patient is stable with the medicine? Yes, cycloserine can be started with medication under cover of psychiatrist consultation, if under the guidance of psychiatrist, which will tell us about the antipsychotic and antidepressant medication, and the medication will be continued for the another 12 months. So continued 12 months should be given under cover of the antipsychotic medication, and whole regimen will be linezolid if patient is having no ADR, linezolid, cycloserine, and clofazimine.
Thank you, Dr. Burana. Thank you for your comments. And now we open this case for discussion. We have many experts also here in the audience. So we would like to hear from you for these three questions. What should cycloserine be replaced with? What should be the continuation phase for this patient? And what if linezolid also needs to be stopped? So with these three questions, we open the case for discussion. We have Dr. Tandon who has raised his hand. Yes, Dr. Tandon.
Ma'am, I would like to emphasize on the fact that for somebody who is having psychiatric symptoms, it would be beneficial for him to be hospitalized for a short duration in the hospital. And also that the previous history of psychiatric diseases, as Sir Dr. Rajendra Prasad sir has pointed out, is not an absolute contraindication to cycloserine. So we would also like to know what exactly the psychiatrist assessment, the mental status assessment was done by the psychiatrist, whether the symptoms were severe or mild or moderate, and what kind of treatment was planned by the psychiatrist in this patient.
Dr. Ankur, can you take that question?
Yes, ma'am. Ma'am, when we started and discharged the patient on bedaquiline, linezolid, cyclo, after 8 days, the attendants were complaining about the behavior of the patient. Patient has become more aggressive. Patient was not sleeping since last few days, and patient was also not taking food. So it was difficult for the attendants to counsel the patient, and because patient was having violent behavior, they brought the patient to the nodal DRTB center on 8th day itself. So due to this kind of severity, we consulted with psychiatrists, and they initially they said that you have to stop the medication. That's why we have stopped cycloserine.
So whether some kind of hospitalization was advised or not, as you have mentioned that the patient was potentially a source of risk for himself.
Yes, patient was admitted in nodal DRTB center itself. Patient was admitted for a week or so, around a week, and after stopping cycloserine within 2-3 days, patient became better because he was taking psychiatric medications as prescribed by the psychiatrist.
Thank you.
Thank you, Dr. Ankur. Dr. Burana, there's a question for you that why are you not considering injectable in this patient as replacement?
Since the patient has already completed 6 months of standard regimen of delamanide, bedaquiline, linezolid, and clofazimine. So according to the guideline, delamanide and in this case, amikacin cannot be started in the last 12 months of the treatment. And since we did in the IP itself, there are 4 much more efficient drugs like delamanide, bedaquiline, linezolid, and clofazimine, which itself are strong bactericidal drugs. So to put the patient on the parenteral IV amikacin, it will cause some sort of side effects also. And according to the side effects as proposed by in the guideline, the side effects of amikacin are also in between in between linezolid and the top is for the linezolid and amikacin also has some sorts of side effects.
Thank you, Dr. Burana. Dr. Alpa, would you like to add something?
Yes, sir. So I also want to know whether any extended DST has been done, because in this case, it is very crucial. A lot of drugs have been already used, like one of the replacement drugs with pyrazinamide and ethambutol was mentioned by Dr. Burana, but it was already used before. So very likely that patient may not be sensitive to it. So here there is a situation with a young patient with bilateral disease and who has got multiple ADR and a bad resistant pattern. So we have a challenge here to have an effective regimen and managing the side effects. So while we are managing the ADR, it is very important that the effectiveness of the regimen should not be lost. So do we have the extended DST on this patient?
No, ma'am. Unfortunately, we do not have any other DST other than H, R, and fluoroquinolone and injectable.
And has he already completed 6 months or not yet?
Ma'am, he has this is July running, and he has completed his 6 months of all oral longer.
Okay. So in this case, because though the guideline says that 6 months of bedaquiline, but the guideline also mentioned that it's the clinician's clinician perspective, and if clinician can decide that if the patient's effectiveness of the regimen is not maintained in the continuation phase, then bedaquiline can definitely be continued. And the way you have described the psychiatrist treatment symptoms, it looks pretty severe. So reintroduction of cycloserine probably may not be the choice. So even if we reintroduce, is likely to go into the severe reaction. So we have to consider the fact that we may not be able to reintroduce cycloserine. So here we are left with bedaquiline, delaminate, linezolid, and clofa. Again, linezolid induced peripheral neuropathy is also pretty common. So I would, in this patient, would like to continue both bedaquiline and delaminate, because otherwise in a patient with bilateral extensive disease with a bad resistant pattern and already exposure to multiple drugs and not having DST of extended DST, phenotypic DST of other drugs, and I think we should continue both bedaquiline and delaminate. And also consideration for amikacin can be considered, because here we have a very peculiar situation where we do not have effective regimen. So, but if 6 months are over, then maybe not amikacin, but continuation of bedaquiline and delaminate should definitely be considered, according to me.
Thank you, Dr. Alpa. That's a very interesting discussion, extending bedaquiline and delaminate beyond 6 months. Dr. Singla has raised his hand.
Yes, thank you. Thank you very much, Dr. Ankur, Dr. Burana, and Dr. Alpa. I find this case is very, very interesting. So many discussions are possible in this case. First of all, in the beginning itself, because of vomiting, a good drug like rifampicin could not be given. So the regimen given by the doctor was ionate, pyrazinamide, and levofloxacin. You see, it's not a very good regimen for even drug-sensitive TB, and I'm sure, as has not been told, doctor was never able to confirm whether we are able to treating drug-sensitive TB or drug-resistant TB. So whenever in this scenario you are giving a regimen which is poor, we must follow up the case very rigorously, clinically, radiologically, as well as bacteriologically, which I think, because reports are not there, we are not sure whether that was done. And the result was, at the end of 6 or rather 7 months, we find patient has failed to the drugs. Patient has already taken drugs like ethambutol, pyrazinamide, which may not be effective now. And it showed H resistance to high as well as low, indicating even ethionamide to be resistant. And also levofloxacin resistance and high dose moxifloxacin resistance. So now we have to make a regimen. Now in this case, you see, at the beginning itself, patient had some psychiatric issues for which patient was given antipsychotic treatment. So to me, it does not appear that this is totally drug-induced psychiatric illness. It could have been that patient has some underlying psychiatric illness for which he required the medication. The regimen which was framed for this patient was bedaquiline, linezolid, clofazimine, cycloserine, and delamanid. So a good drug like quinolone we could not give. Now even cycloserine, because patient had underlying the psychiatric illness within 7-8 days. Usually you see cycloserine psychiatric illness does not occur in 7-8 days. That has been the usual experience. So it was quite likely that cycloserine was not tolerated. And the patient was left with only 4 drugs. That is bedaquiline, linezolid from group A, and clofazimine from group B, and delamanid from group C. Again, not a very strong regimen, and the culture DST was not available. So if I was there, I don't mind starting amikacin from the beginning. Even at that stage, when we were starting the all oral longer regimen, and in absence of the levofloxacin or moxifloxacin, in absence of cycloserine, I could have added amikacin to make the regimen more robust and more bactericidal. And now we are left after 6 months, where we are is that bedaquiline patient is tolerating bedaquiline, delamanid, clofazimine, and linezolid is there. And it is time to think of whether we should stop bedaquiline, delamanid or not, and what is to be continued. And as has been discussed by Dr. Ankur also, his question is, in case he does not tolerate even linezolid, which is a common scenario in the field, what is to be done? So in this case, as Dr. Alpa said, we should continue all the 4 drugs, that is bedaquiline, delamanid, linezolid, and clofazimine, with the thought that in case even if he requires the linezolid to be stopped, we have 1 group A drug, bedaquiline, 1 group B drug, that is clofazimine, and 1 group C drug, that is delamanid. So this is a case scenario where we have to continue all, because if you go for the replacement sequence, ethambutol and pyrazinamide will not be good drugs. We do not have DST, and patient has used them for 6 months, 7 months, and has failed to treatment. And imipinam, again, logistic issues are there, and to give injectable treatment after 6-7 months of treatment is not a preferred scenario. So in this case, in the continuation phase, I suggest we should continue with bedaquiline, delamanid, linezolid, and clofazimine, and also keeping in mind that we should always try to make a robust intensive phase. That could have been done by adding amikacin from the beginning, after we found that cycloserine was not a problem. Thank you.
So there is one question in what you said, that to extend bedaquiline and delamanid. Then how long to continue this bedaquiline and delamanid in the extended period?
Usually, you see, whenever we do this, because in case you stop this, you are left with only 2 drugs, that is linezolid and clofazimine. Usually, we have to continue till the end of treatment. But in case patient is doing well, clinically, radiologically, microbacteriology, after say 6 further months, that is at the end of 12 months, we can think of stopping delamanid and continue with bedaquiline, linezolid, and clofazimine. Or some people may argue that continue with all the 4 drugs till the end, even that is correct. Because in these cases, in case now patient relapses or there is a recurrence of disease during the treatment, that is called he's a failure to treatment, will not have any drugs. So I don't mind to continue all the 4 drugs till the end of treatment. And we have sufficient experience, patient tolerate such combination of bedaquiline, delamanid, and clofazimine. Thank you.
Are there any questions?
Dr.
Yeah. So, Dr. Rajendra Prasad, sir, for your comments.
Thank you, Neeta and Rupak, for inviting me, national expert. There are certain points I would like to point out. As the history tells, that patient was first, what I could understand, went to some government clinic where he was provided category 1 dots, through which he developed intolerance, probably rifampicin, pyrazinamide. Now, question is, when he was started category 1 dots, it is not there in the history whether the gene expert was done at that time or not. Whether he was, in my mind, what it was coming, whether it was a primary drug resistance or it is acquired drug resistance. Probably the first time, because treatment was started in 2021, where gene expert was completely in the picture. So whether it was done or not, that I wanted to ask.
So patient did not have previous CB-NAT or first line LPA report of his first episode of ATT, that is HRZD. Patient did not have previous reports.
So that is the scenario, you know, we always talk of universal DST. At least in 21, ideally it should have been done. And we should have known that whether he is a primary rifampicin or MDR-TB, or he has acquired. He might have acquired because of drug intolerance. He took treatment for about 1 month and then the treatment was reduced. That he may have acquired also, but we should have known. One more, the second more thing that was disturbing to me, he went to the government, he was provided category 1 treatment, he developed some drug intolerance. Actually, the government should have been able to hold the patient. And here is the role of health education. Maybe on the paper we have that, yes, every patient is given health education. Because if I treat today tuberculosis, even I treat today tuberculosis, I tell every patient whom I am treating that you can develop these adverse drug reaction during your treatment. Don't be afraid, come to me. Nahi to kya hota hai, what happens? He goes to some another doctor and then he treats. So this thing, to my understanding, this thing has to be fortified since the case belongs to Rajasthan. So my request is it has to be fortified in the state of Rajasthan. That if somebody develops drug intolerance, this is obvious in 5 to 10% patient have some drug intolerance to the primary line of drug. So at that time, this system should be robust, health education should be robust, so that patient comes back to you and there should be effective management of adverse drug reaction and subsequent issues. That was another issue which comes to my point. And I was pretty sure that from history to me, it looks like he has some background of psychiatric illness. Although it was not, he might not have told, but psychiatric illness is not so easy to recognize by the patient, but it is the person, it is the doctor who has initiated the first line treatment. At that time, ideally, if you discuss in detail, you come to know that what is his personality, what type of, that is why maybe that he might not have tolerated the cycloserine, and cycloserine ultimately has to be stopped. And third point I would like to know, as he has completed 6 months of treatment with good drug, I may say, very good drugs, 4 drug at least, 5 drug to begin with, and then 4 drug. What is the current situation of sputum smear or radiologically or clinically at the end of 6 months? That should have also been there in the case. You have shown 2 X-rays. I don't know the last X-ray, maybe at the end of 6 months or before that. So what is the current status of clinical picture, radiology, and bacteriology? Bacteriology means, when I say bacteriology, it is just because follow-up is done by the sputum smear. So what is the current status?
Sir, clinically, patient is now stable. Patient, we didn't do the X-ray of the patient in the follow-up because 6 months is now, at this time, 6 months is now completed. Now we have to call the patient for the extension of the treatment and all the evaluation. In the meantime, in the month of March, the same patient had developed QTC prolongation because we every month, every bedaquiline patient is evaluated by monthly electrolytes and ECG and basic lab work at our center, and we found in the month of March that patient had QTC prolongation. We admitted the patient for 3 days, then was managed accordingly according to the guidelines, and was discharged with normal QTC. So
Okay.
this patient has developed one more side effect of the drug. This is in addition to the previous history.
Okay.
We
That you have written in, yes.
we do not have, sir, right now, we do would have the new X-ray and sputum status. We do not have it
But- Yes, yes. So that I totally agree with what Alpa and what Rupak has said, that if we know that patient is improving, even these drugs would be sufficient. And in case of, yes, we may extend the duration of bedaquiline, and if he is responding to these drugs, may not that we may be able to stop at the end of 6 months if other drugs are not available, because the group C drugs are weak drugs anyhow. And so if he is improving with these drugs, and this might be extended beyond 6 months also, as the even guidelines says also. So my take home message is this: the program, always we say that, I'll repeat at every occasion that science, we have progressed science wise very well, but still the implementation issues, managerial issues, they are still, as you know, in this case, even we don't have any culture and DST phenotypic. And somebody was talking about extended DST. So those things, because he's a young man, his life is to be saved, and it is the effort of the doctors wherever he is being treated, we will able to save his life, because he is a bilateral disease. And from your statement, it looks that he is clinically, he is improving. That may be confirmed by bacteriology and by radiology also. So I agree with Rupak and Alpa and other experts that yes, the line of management, what they have discussed. But that shows us very clearly that we have to improve our implementation issues. We have discussed time after time, long turnaround time of these investigations, which ideally should be less. Problem of DST, especially the extended DST. So in that we have to improve, and then we may be able to save many patients of tuberculosis in this situation. But still, I'm not clear whether this patient was a primary drug resistance. Rupak, you can add to it, or he has acquired drug resistance. The type of history what has been told to us. I'm not clear in my mind.
As I think I totally agree with you that in this case, it is not very clear whether he had resistance from the beginning. But the very fact that he could not receive a good regimen, he received a regimen of INH, ethambutol, pyrazinamide along with levofloxacin, that too after 1 month of treatment. So a poor regimen can also lead to drug resistance. So both the possibilities are there. But in such situation, I always feel we should increase our level of monitoring. Whether it is clinical, whether it is radiological or bacteriological, even that is not there in the case. Straight away, we are told that at the end of 6 months. So I think that facility where patient received the initial treatment did not do the follow-up investigation as it should have been done. Otherwise, we could have caught this patient much earlier, because by the time now 6-7 months of the treatment are over, we have lost even drugs like ethambutol and pyrazinamide. So from the replacement sequence also, if you see, the drugs like ethambutol, Paclitaxel, they are not there. PAS is nowadays not available. So we are left with very, very few the choice to be made in such cases. Injectables are not very good in the follow-up period after 6 months of the oral regimen. So that makes our hand very tight. One thing more.
Yes,
yes. Yeah, whenever these patients are on bedaquiline, denabinate, clofazimine, then we should take it very seriously, the ECG monitoring as well as electrolyte monitoring both. Because sometimes they go for increase in the QTC interval and it is also missed. So at least what we do in our center is at least a monthly, if possible twice a month we do this. And even if the QTC F is more than 480 milliseconds, but the electrolytes are normal, we do not do anything, we just increase the monitoring. On the other hand, in case the QTC interval goes more than 480 milliseconds and the electrolytes are normal in the form of the potassium is low, calcium is low, magnesium is low, then we have to hold these drugs, first correct the electrolytes, and then introduce them one by one. So a good monitoring whenever we are using cardiotoxic drugs is a part of the monitoring of this patient. So that also we need to keep in mind. Thank you.
And I agree, Dr. Rupak, with you that you said that maybe in the program, the X-ray may be at the end of 6 months. But in such crucial cases, even we may deviate. X-ray is done in every clinic and every hospital. So we may deviate and we may know that whether. So what I say that probably you have to work on a mission mode with every patient who is especially little critical. And then we might help the patient and might save the life of that patient. He is a very young guy. So every effort is to be done in this case. What is my request to all the team who is treating this patient? Thank you. Thank you, Rupa.
Yeah, thank you, sir. Dr. Ankur, did you get a 3rd month culture or the 4th month culture in the all oral regime done?
Ma'am, we didn't have the reports till now.
But are the cultures sent?
Cultures have been sent. According to the patient, cultures have been sent.
Oh, yeah, Dr. Alpha, you want to add something? Dr. Alpha, we can't hear you.
Unmute.
She's saying, can you check?
Let me send you an unmute request.
Okay. Yes, yes, sir. Can you hear me?
Yes.
Yeah,
we
yeah.
can.
Yes. So as Singla sir and Rajendra Prasad sir has already pointed out, so I just wanted to add to it that this is quite a common scenario. It is not all that uncommon, the case that Dr. Ankur has discussed. And many times, like one such case is being brought to the echo clinic for discussion. But many cases are routinely the bedaquiline gets stopped at the end of 6 months. And these cases don't come up for discussion. And we see that initially 6 months, probably patient starts to respond clinically and maybe radiologically also, and the bedaquiline is stopped. So we should really have far-sightedness and think about the future possibility of one more drug ADR developing, and we of the regimen has to be really considered, because our being a referral center at TB hospital, so many such young patients, they come after end of 6 months, after bedaquiline is being stopped, and both their lung get fired and then they are put on oxygen. So in our ward, sometimes 50% of them are such, and it is so painful. And at that stage, when both their lungs are fired, we really cannot help them even after changing the regimens. I think this is extremely important message for everyone, that in such cases, one has to be very vigilant. Another problem that happened, that many of these patients get once initiated at the nodal center, and then they continue to follow up in the periphery center. So at nodal center, we have to make sure that these patients follow up with us, so that we can keep a check, and at the crucial time of changing from IP to CP, we take the right decision.
Yeah, Dr. Alpha, you said that very right. Even here at NITRD, we observe that, once we start the patient and we send back to the district, the patients are not being followed at district for various reasons. And I think every patient should be followed at least once a month by the district TB officers, so that these patients don't get neglected for their ADRs or for change of regime or for any other reason. Dr. Amitesh, we have a question.
Yes, there is one question to Dr. Rupak Singla. As patient was not able to tolerate paracetamide, what will be your choice? Initial regimen in addition to EZH.
Okay, thank you, Dr. Sudarshan. You see, actually, it was the treating physician thought patient was not tolerant to rifampicin. So the physician decided to give ethambutol, pyrazinamide, INH along with levofloxacin. But again, especially as we discussed also, we were not aware whether patient was rifampicin sensitive, rifampicin resistant about the. So in the beginning, we were not even sure patient belongs to drug sensitive group or not. A better regime could have been to add streptomycin also. So you should have streptomycin ethambutol, pyrazinamide, INH along with levofloxacin. That could have been a better choice, and patient could have responded to this regimen in case that was given. And again, even on that regimen, patient should have been followed up with clinically, radiologically, as well as sputum-wise, whether patient was achieving sputum conversion or not, rather than waiting for 6-7 months and then reporting that patient has failed to treatment and now is showing resistance. So that was equally important to follow them up methodologically. Somehow we are noticing in the field whether patient is on shorter bedaquiline containing regimen or a longer regimen, the cultures are not being done. Or if they are being done, either the reports are not being collected from the Nikshay, or the reports take long time to the tune of 2 months, 3 months, 4 months. And we'll end up in scenarios that at the end of 6 months, we find that either we do not have the culture report, so that we are not sure patient has converted or not, or the report is still not awaited and we are forced to go to the continuation phase without a report of pathological conversion. So it's a request to all our DTO colleagues that they should, in these cases, they should talk to the laboratory. They should make a 9 listing of the cases where the culture report is not available at the end of 4 or 5 months, and talk to the laboratory, check the Nikshay also, whether report is available or not. So that will reduce many of this drug resistance development during the course of treatment. Thank you.
Thank you, Dr. Singla. But I think the take-home message in this, from the discussion that we are getting is supervision and monitoring is something that is really lacking at every level, whether it is STS, STLS, our MOTCs, all the supervisory. So if we are able to supervise the patients at the field level, many of the things can be taken care of. Dr. Rajendra Prasad, sir, you wanted to add?
Nita, as somebody has raised a question of hepatotoxicity, thinking that in a drug-sensitive tuberculosis, this is a problem which face we day in, day out. As a clinician, what is the evidence at present is saying? What Rupak said is very right, that if somebody developed a hepatotoxicity, say symptom-wise, you do LFT, and if the SGOT-PT raised more than 5 times, or raised more than 3 times with symptoms, or serum bilirubin is raised, then what usually we do, depending upon the case, because he was simply a case of bilateral tuberculosis. So what usually is done, that in the scenario, if there is a serum bilirubin is high, enzymes are very high, we might stop treatment for about 5 to 7 days. And I am pretty sure that with my experience, many of the patients, if it is not, forget about the drug-resistant TB, I'm talking of drug-sensitive TB. So many of the patients, they improve with the stoppage of drug. And after the LFT has improved, maybe after 7 days, 8 days, what usually is done, and whether you read ATS guideline or ERS guideline or any guideline, they say that first, after the patient has become normal, LFT has become near normal, then you may start with the hepatosafe drug. And in primary line of drug, hepatosafe drug, best, as Rupak said, streptomycin is very safe. Then ethambutol is very safe. Even in India, I believe INH is also safe. Although in the Western literature, this is a culprit, but in Indian patients, we have seen they tolerate. So, and after when they tolerated these 2 or 3 drugs, maybe after 3-4 days, you have to reintroduce rifampicin and pyrazinamide in sequential manner. So, and many of times we have seen, if it is drug-sensitive tuberculosis, they tolerate these drugs and they complete the therapy. So that is how, that is what is my experience in managing the hepatotoxicity, especially in the drug-sensitive tuberculosis. Although the same rule exists for the drug-resistant tuberculosis also, if you read the adverse drug reaction management, I mean, that is the place where more vigilance is required. This is the place where patients are lost up. Patient change the doctor, patient change the clinic, and that should not happen. If one is vigilant, if one health education or health literacy is very high in the clinic, or with the doctors, or with the clinic, patient will come to you again, and you will be able to, majority of them, you will be able to manage it. Yes, when they are not tolerating rifampicin and paragenamide both, then one thing must always kept in mind. If you are not able to continue rifampicin and paragenamide in a drug-sensitive tuberculosis, then the duration of this treatment has to be prolonged, minimum of 1 year. That is how liver, adverse drug reaction of liver, to me, is managed in the drug-sensitive tuberculosis. Thank you, Neeta, for giving opportunity.
Thank you, sir. There's a question for you, sir.
Sir, there is a question that how long can streptomycin be continued in a patient having TB with liver disease who is on levo regimen?
Streptomycin usually, depending upon the case scenario, usually come to 2 months is a minimum, and that is daily regimen usually. If you may go up to 3 months, and then when you are using these regimens, say streptomycin, INH, ethambutol, even levofloxacin, suppose you are using, ideally should not use it. Then the duration is not 6 to 9 months. Duration is minimum of 1 year with initial streptomycin for 2 to 3 months. That is what is the practice.
So here one thing, like what exactly, if you see the question, if patient is on SE, streptomycin, ethambutol and levofloxacin. So in this case, INH, rifampicin, paragenamide, all the 3 drugs are not being used. So I think such a regimen for long may not be good. And in this case, 2 or 3 months of streptomycin, and after that we'll be left with only levofloxacin and ethambutol.
No, ideally, what Rupak, I was going to say that the drug must have been tried. Actually, he went to some private practice whose knowledge may not be as sufficient. So in this scenario, if it is a drug-sensitive tuberculosis, imagine, then those drugs must have been tried again. And if he is, and many of them we have seen in our clinical practice, and you will agree that many of these patients, they retolerate even rifampicin and they retolerate even paragenamide. Very few patients, they show real adverse drug reactions.
So that's what I'm saying. So in these cases, in case they must try seriously the reintroduction of INH, rifampicin, paragenamide.
Yes.
Usually,
yes.
as you said, INH is usually well tolerated. But in case you find a patient where neither of the 3, that is INH, rifampicin, paragenamide was tolerated, and we are forced to give only streptomycin, levofloxacin and ethambutol, then after stopping streptomycin, only 2 drugs, that is levo, ethambutol, will not be good choice. What we do in our center, in these cases, we have to add some drugs from the second line drugs. Like sometimes we have to add even linezolid in these cases, because only 2 drugs in the continuation phase of levo and ethambutol may not be a good choice even in drug sensitive case. First of all, as you said, we should make all efforts to see which of the 3, usually INH, should be tolerated by the patient, and we should give it. In case rifampicin is tolerated, we should give rifampicin. But if none of the 3, INH, rifampicin, paragenamide, is tolerated, then we should have another drug which will be from the second line sequence, and even linezolid can be tried in these cases. And we have had some cases where we had to do that, and patients, they did tolerate that.
Yes, Rupak, I totally agree with you. Yes.
Thank you, sir.
Thank you, sir. Are there any questions? Are there any questions from the audience?
That is long.
Yeah, so is there a question?
Yes. So another question which is there in the chat is, does terrazidone have lesser psychiatric adverse reactions as compared to cycloserine? Yes, it is usually given in the books that terrazidone leads to lesser adverse reaction in terms of psychiatric illness than the cycloserine. But frankly, my own experience of using terrazidone in place of cycloserine is very, very limited. And I may request Dr. Narendra Prasad to share his experience of paracetamol in phase.
I think same is true with me, Rupak. We have very extensively used cycloserine in last 40 years. Even before MDR word, we were fond of using cycloserine. But we have not much experience with terrorism, because terrorism is usually not available in this part where I live. So we have, but as you said rightly, what book says that it is little better tolerated in terms of psychiatric illness. But my experience is once patient develop a psychiatric problem with cycloserine, many of times probably it is better to stop the drug, because I have seen at least 3-4 suicides with the cycloserine. So you have to be very careful. You have to see the patient very careful. We have to take the opinion of psychiatrist, and then but fortunately, this side effects, I may say serious side effects of cycloserine is not very common. Hardly we see in one of his study, and Rupak will agree me, we see about not more than 5 to 10% patient, 5% patient may have to resort to stoppage. Many of them, they tolerate with the psychiatric help, with the some drug. But once the suicidal ideation comes, but that drug become a totally contraindicated.
There is another question on the chat, that is as regards to hepatotoxicity is concerned, which drug, rifampicin or PZA, is to be restarted first? So as we already discussed, usually we start with INH, that is the usual practice. And then usual practice is rifampicin, then pyrazinamide. Although when they reviewed, they found that pyrazinamide, earlier time we were using a very high dose. So it became still famous that this is the drug which causes maximum adverse drug reaction in terms of hepatotoxicity. But I may request Dr. Narendra Prasad also to share his experience. We in our practice, we start with INH, then rifampicin, and then pyrazinamide. That is the usual practice which we are following. Sir, what is your take on this?
The same way. Same way is my practice. If you read, there are two way of reintroducing. One is the European guideline, and another is American guideline, ATS. So what American guideline says, you have to reintroduce, say, ethambutol, streptomycin, ethambutol, as far as hepato safety is concerned, and then you can go to the INH, and then go to the rifampicin, and last go to the pyrazinamide. But the American says that same thing they also say, but they have some reservation with isoniazid. But usually in my clinical practice, what I have seen in more than 4 decades, that isoniazid is very well tolerated in terms of hepatotoxicity in Indian patients. So what Rupak said, the same sequence I do follow.
Thank you, sir. Thank you very much. So coming back to you, Dr. Ankur, the questions that were raised by you is what should be the continuation phase. So as it is decided by the expert, they would like to continue with bedaquiline, delaminid, linezolid, and clofa. Your next question was that if the linezolid needs to be stopped, what should we do? So it should be you continue with bedaquiline and delaminid and clofa for your continuation phase. And third was whether cycloserine should be restarted or not. That would depend upon the psychiatry evaluation, whether you want to. Generally, when psychiatrists don't recommend that it should be started. So that has to be decided with consultation of a psychiatrist. But in the background of all this, we have realized that there's a need for supervision, monitoring, right from the day one when the patient is enrolled in the FDC, because as we see in this case, we don't have the initial CVNAT report, and then we don't have follow-up smear reports. We came to know only once the patient failed, and similarly, we don't have any culture or X-ray report as of now. So background of stricter monitoring and supervision, these are the 3 decisions taken. So do you have any questions with this?
No, ma'am. Thank you so much.
Ma'am, may I come in?
Yeah, sure.
Ma'am, I am Dr. Vinod Garg,
So I was
STO
going to
Rajasthan.
invite you only as STO
Okay,
Rajasthan.
okay.
It's our pleasure to have you.
Thank you, ma'am.
Thank you so much for joining.
Thank you, ma'am.
Yes, sir.
Ma'am, we are conducting these difficult to treat clinics regularly in Rajasthan, and till now we have arranged about 11 clinics. And all our experts are participating in these clinics, and our DTOs are getting benefits from these clinics. Ma'am, in this particular case, a major question remains that why NAT was not done. And if there was some problem regarding cartridges, the sample could have been sent for LPA, so that at least we can get the result regarding rifampicin and INH. No doubt this is a very big question. Second, ma'am, regarding health education, as sir said, it is a basic thing. I usually ask my DTOs and all the MOTCs and STSs that please invest your 10 minutes to save your 6 months. If you will not invest 10 minutes to each patient, you will have to be busy with same patient for the next 6 months. And this is the same case. We can avoid the ADRs only by good health education to the patients. Ma'am, my question is that cycloserine, generally psychiatrists, they avoid to give cycloserine. If we refer the case to the psychiatrist with the complaint that patient is having such type of depression or whatever, the first treatment is stop cycloserine. But if we explain that now at this point, cycloserine is very important for us, patient is of DRTB patient, then they can advise to continue the cycloserine under the good coverage of antidepressant and antipsychotic drugs. They generally do not take any type of risk. If we pressurize them to let us allow the cycloserine under good coverage of drugs, I think they can help us. Ma'am, one thing said that pass. Till now, no comment on the pass. And next, my point is, ma'am, this is a general practice. If patient develops hepatotoxicity after 4 drugs, which we are giving for 4 FDCs, we just stop the drugs. I am also a clinician, ma'am. We just stop all the drugs, as Rupak sir said. Then we wait for 7 to 8 days, let the LFT come normal, and then we start hepato-safe drugs as ethambutol and streptomycin. And if we can also add the levofloxacin and then INH and then rifampicin and then pyrazinamide. This is a good practice, but I do not know why this practice was not followed in this case. It is very sad. I hope the patient could have been improved with all these 4 drugs. And it is my duty, ma'am, to convey all the DTOs and their colleagues to invest some time on the health education. I assure you that we will improve in this matter. Thank you, ma'am.
Thank you so much, sir.
Yeah, Dr. Vinod, thank you very much. I think besides other points, you have raised 2 points, that is about cycloserine and pass. And I fully agree with you, and we have seen this in our practice also. Whenever you send a patient of MDR-TB who has some psychiatric issues to a psychiatrist, their first question or first answer from that side is stop cycloserine. So we have to discuss with them in detail that this is not a routine case. This is a case of MDR-TB. Cycloserine is an important group B drug, which is very, very important for that particular patient. And in context of that, we should request them to reconsider whether we can continue. However, in this case, you see there are 2 types of patient. One is patient having underlying psychiatric illness. And then once you give these drugs, cycloserine, patient develop increase in the psychiatric symptoms. Second is a drug-induced psychiatric illness. So what I have seen in my practice is that in patient, like in this case, I feel patient had some underlying psychiatric illness. So even during the beginning of the assessment, they found some psychiatric illness. He was put on some antipsychotic medicines. Even when overall longer regimen was started, he had some psychiatric issues for which it was stopped. And now, by now, patient is already stopped cycloserine for 6 months. So it may not be a very good choice at this stage to add this. But in general, we should make all the efforts to retain this drug. Regarding pass, yes, nobody discussed about this because it is not available now. Unfortunately, although not a very good drug, but when we are cornered, that we cannot give ethambutol, we cannot give pyrazinamide from the replacement sequence, we cannot give ethionamide because INHA mutation was there. So in these scenarios we come to the point of PAS. But now, you know, whatever is available in the market is 1 gram tablet of PAS. In case you need to give 14 grams, 14 tablets of PAS, one can imagine how patient will consume. And we've also seen, we have used in the PAS tablets also, that they come in this stool as such. Somehow they are not absorbed well. Many times I have noticed that when I prescribe the PAS tablets, they come out in the stool as such without getting absorbed. And I just cannot imagine a person to take PAS only 14 tablets or 16 tablets besides the other medicines. So that is the reason that please explore in Rajasthan whether PAS is available or not, so that in desperate situations where we are cornered, we are able to consider PAS to be given in these patients. Thank you so much, Dr. Vinod, and we are grateful to you for your support for this state level difficult to treat TB clinic. And I'm very happy that that was our aim also when we started the national level difficult to treat TB clinic, that the state should come. When the states they take over, they have their own experts at the state level who present and discuss the cases. And whenever they need any hand holding, of course, our national experts are there. And we have good people, experienced people like Dr. Rendra Prasad, Dr. Mehra. Many senior people are there who are able to guide us in these difficult cases. Thank you once again.
Thank you, sir. Thank you very much.
Thank you, Dr. Singla. So we would request everyone, you know, to motivate all the district TB officers and people from DRTB centers to attend these clinics, so that we get benefit of this collective wisdom, that is the discussion that is generated here, and the you know, learnings that we take from these clinics. So with this, now I request Dr. Ashok Bharadwaj sir, who is the chairman, National Task Force, and who is been supporting these clinics right from the beginning and encouraging all the medical colleges to join us. I request Dr. Ashok Bharadwaj sir to propose the vote of thanks.
So thank you, Nita. Thank you. So happy Guru Purnima to all. So I must thank the team Rajasthan, Dr. Vinod Garg, Dr. Ankur Gupta, for their nice presentation. It was a very, very, very interesting case, and we were benefited by the opinions of a person like Dr. Rajendra Prasad, Dr. Rupak, Dr. Alpa, and the last Dr. Vinod. So I also compliment Dr. Garg, the STO Rajasthan, because they are running a state level clinic with quality elements. So I am attending the clinics of other states also, but somewhere quality is missing. But their clinic, they are all DTOs they join, and they have got a big attendance. So Nita, today attendance, so I must say that we had only less than 300 people, because a joint sportive supervision mission is being undertaken throughout the country, and where the STOs of the states, the DTO of the state where district has been chosen, they're all engaged in that. So that may be one of the reasons for low attendance in this case, but this was an interesting case, and we have become wiser by this. So I fully agree with Dr. Vinod Garg that we must spare some time with the patient. So if we spare 6 minutes, then we can save 6 months. So thank you, Dr. Garg. And as far as I know, Dr. Garg, in all DRTB center, we have got counselors. And
Sir.
These counselors, their primary responsibility is to counsel the patient. So once the patient is counseled, Dr. Jindal has also reiterated this point for health education. So we move one step ahead, because the program has posted counselor in each DRTB center, and we must utilize the services of these counselors. Am I audible?
Yes, sir, you are. Sir, बीच में आवाज चली, हाँ.
So मैंने वो बीच में so so Nita, guidelines are specific. DRTB guidelines of 2021 is very clear. So these guidelines should be available at each DRTB center so that they can refer to it. As always, Dr. Singla says, Rupak Singla says that at some times we have to tailor-made the regimen. So it may not be always there in the guidelines, but we have to tailor-made, and these clinics as well as the state clinics are there to help us and to support us so that we can benefit from the experience of other people. So thank you all for giving me a chance for this important clinic. So thank you, Ruth. Thank you, Singla, and thank you, Anita.
Thank you so much, sir. Now we are floating the poll. Kindly answer the questions. We need your feedback so we can improve further. Have you put the poll? Yeah, so kindly answer the poll. Yes, Dr. Rishi, you have raised your hand. Dr. Rishi, please unmute yourself.
Yeah, yeah, madam. We have a new STO, Dr. Shailen Bhatnagar. He has joined day before yesterday. So, and he has been the founder of a UP State TB clinic. So, sir was busy in some other optional work. So, sir wants to say something, sir.
Kindly answer the poll questions.
Shailen, you are not audible. Dr.
New
Shailen.
So we would like to thank Dr. Rajendra Prasad sir, who's always supported us. Then we have all the faculty and the DTOs who have been joining us regularly. We thank you a lot, and we request you to join our subsequent clinics. We look forward to meeting you in our next clinic. Thank you.
Thank you, Nita and Rupak. Thank you, everyone.